I guess the question is, clearly our methods for testing HER2, what we're really trying to find, obviously, is who's going to respond and who isn't to an anti-HER2 agent of some sort, be it pertuzumab, be it trastuzumab, be it lapatinib. And the issue is, I think there is some kind of concern that the current methods we have do leave people behind, in terms of either leave them behind or mischaracterize what they are. And how would you approach that problem? I know we're a little off topic here, but I think it's an important one that people ask a lot.
I think that we, in general, when it comes to picking treatments for our patients, need to stick to the ASCO-CAP guidelines, because there are a number of other things with RT-PCR, PCR, which I think are very fascinating to look at in research studies. But from the clinical standpoint, I think we really want to look at the ASCO-CAP guidelines. And they've recently been revised, and it's 10% of cells now 3+ positive or not, and it's ratios over 2 or HER2 gene copies over 6. And so I think they're a little bit more helpful to us in the clinic. They're a little bit more liberal so we don't lose the patients. But I think we really have to stick with the ASCO-CAP guidelines that really have been validated in the clinical studies.
I agree, and you do have the study to treat patients with trastuzumab, the NSABP trial, and then I think that'll be very interesting in terms of looking at the tissue that's all being collected to see whether or not there's another way to validate response. Right. But until then, it seems premature to be using expression arrays to determine who should be treated with trastuzumab. Now, we all end up with those patients who have disease that looks HER2 negative, although I must say I've seen very few of them, less than one hand worth, who are HER2 positive on a expression test, Oncotype DX mammoprint. And also the reverse, somebody who's clearly got HER2 positive disease but is negative on expression. I think those are really the clinical examples of what Mark was talking about. And generally, I think we treat those patients as if they're positive because we don't want to miss them.
So we in other words, just to summarize this, take a broad, find reasons to treat people as opposed to not with anti-HER2 agents.
Well, because there's a proven survival benefit in however you define it, utilizing these agents in HER2-positive breast cancer that we just really don't want to miss providing to patients.
The other signal that might afford an expression array HER2-like phenotype, and I'm speculating here, but there are a small fraction of HER2 kinase mutations in HER2-negative breast cancers that are negative by FISH and negative the protein level, but if you sequence the kinase domain, they have mutations. This genotype is enriched, for example, in some lobular phenotypes, for example. So one wonders whether activation of HER2 by a kinase mutation might give you a transcript profile analogous to a HER2-like tumor, even in the absence of gene amplification or protein overexpression. But it's speculation. I haven't seen the array phenotypes of those rare mutations. It's only about 2% of breast cancers, according to Matt Ellis's publication.
But are they? But I guess the question is, are they HER2-like when you do intrinsic subtyping?
We don't know.
Right. No one knows.
That hasn't been done.
Cool.
It's only rare.
Very good.
One other thing with the TDM1 pertuzumab, I think that's interesting is from our colleagues that are looking at gastric cancer and have been looking at TDM in different schedules with a weekly dose. There's been some signals of efficacy in that group as compared to the Q3 week. So we're actually going to be doing a prospective, trying to get a biopsy up front as a first-line setting for metastatic, hopefully to add on the Marianne trial with a weekly TDM pertuzumab schedule. So hopefully with the biomarkers and looking at that schedule, we may see some further exploration of that combination and adding on to that whole frontline therapy with Marianne and see if there is a signal with a weekly schedule.
And you're giving weekly TDM1?
Weekly TDM1.
And then weekly pertuzumab?
We're doing weekly pertuzumab.
Interesting.
Or given an option of weekly or Q3, but they'll be in weekly for the TDM.